everyone. Hope you're all doing good. Guys, welcome back to RRR series, which will help you to master the questions, because basically every time when we do it very differently. This time, the more demand was for solving the questions and approaching the questions. We are going module wise. So today I'm going to do the post-op module. As you know, there are not much of questions, but I have combined few questions which are commonly asked. I hope this would be of help to you. Definitely always remember, you are always unique and that's your power. So you might be going right in a lot of things. You might be going wrong in a lot of things. Let's strengthen your strength and help you to strengthen your flaws as well. Okay, so let's start off. So I'm going to do this first SBA single best answers followed by EMQs. So I'm going to follow the cover test for all the SBAs and EMQs, the approach which you guys need to be doing. Let's start off. So whenever you read a single best answer, ideally, the first thing should always be to understand what you are supposed to be doing. So in this question, whenever I've been given a question, I always read the last line first, because there are a lot of things which I need to be reading. So here, which is the most appropriate investigations for this scenario? So I'm dealing with a 45-year-old woman who has underwent VVF 2 days, who has underwent surgical repair of a VVF 2 days ago. On post-op day 2, she complains of a feeling of dampness in the vaginal area. Surgical team suspects a possible urinary leak and wants to evaluate the integrity of the repair. Which investigation is most appropriate? Actually, if you see here, the scenario is very different, because generally what they are trying to ask is not the diagnosis of VVF, but somebody who has undergone the repair, and they would want to see what is the investigations which is appropriate, because on the post-op day 2, she's still complaining of dampness. So they want to see from where the urine is leaking. So definitely the first culprit, what you need to think, whether you can see the investigations, obviously you have to think of bladder and ureter. So these are the two options which you think. And when you see in the options, you have got all possible options. And this is quite a simple one, because the first and the always suspicion would go for the one which you have repaired, right? What is the integrity of the repair? So you are not suspecting anything to do with the ureter, because you have just repaired a VVF. You would want to make sure whether this is correct or not. So it's a simple logic. I don't think there will be any issue. Generally, people would give you, okay, they have undergone vaginal hysterectomy, there is a dampness, what is the one which you need to do? So in case of diagnosing VVF, the best thing would always be the bedside test to see from where the leak is coming. But to identify whether it is lower or a higher one, or whether it is ureteric injury or that it's a bladder injury, there is a whole lot of investigations which you need to be aware as well along with this. Let's move to the next one. The next one is, what is the most likely diagnosis? Fine. They are giving me a scenario which I need to diagnose. 52-year-old woman who reviewed 12 hours, is reviewed 12 hours after an uncomplicated total abdominal hysterectomy. So I'm seeing a post-op patient the same day, 12 hours after. She had a blood loss of 400 ml. She has undergone hysterectomy for fibroids. She complains of diffuse abdominal pain and distension. On examination, abdomen is distended but non-tender, but bowel sounds are present. Blood test shows raised creatinine and urea. Obviously, here I have made the life easier by giving you it is raised. In the exam, they could just give you the values. And always we think of immediate post-op, we think of hemorrhage. But since the blood loss is given minimal, but they haven't mentioned of tachycardia, hypertension, or the distension, you should think of I'm keeping my hemorrhage aside, because they have not mentioned anything about the hemodynamic things. But what they have given me is creatinine and urea is raised. So either there is a problem for the kidneys, either for the ureters or for something else. So let's see what is this scenario. So keeping those two differential diagnoses in my mind. So first thing is bladder injury with uroperitoneum, very much possible. Paralytic ileus could be, but because creatinine and urea doesn't have a value there. Ureteric injury causing unilateral obstruction, possible, but it is very early because it's 12 hours. Peritonitis due to bowel injury, again, it is very early to set in. And AKI from hypovolemia, if it was so, they should have mentioned about the urinary output as well as the other observations. So obviously my obvious choice would be bladder injury with uroperitoneum. Obviously they could give you the specific gravity and all. I have kept it very simple, but please remember, whenever you get something like this, quickly rule out the differential diagnosis, because post-op complications is all about understanding the differential diagnosis. So hope this is helping you to get the approach. I'm not going ahead and telling, okay, how to diagnose paralytic ileus. We are not going to divide each option. My point is to help you understand how you come to one conclusion, because that's what is always complicated for a lot of people, right? Let's move on. Again, it's the explanation of the correct answers which we have given. Remember, the uroperitoneum, always the symptoms would be like abdominal pain and tenderness, and definitely suprapubic discomfort could be there. Definitely, there could also be symptoms like hematuria and so on, and creatinine and urea will be there. And the best investigation to confirm is CT urogram for sure. The next one. Okay, this is factual recall, because they're asking me about the most likely nerve affected. So let me see what is the procedure and what is the function of the nerve. 48-year-old presents to the hospital 3 weeks after undergoing SSF for uterine prolapse. So I know the answer already, but let me go through. She complains of worsening gluteal and vulval pain, sharp and burning in nature, significantly worse when sitting, but when standing improves when she's standing or lying down. No urinary or bowel symptoms. There is no evidence of infection. Tenderness is noted in the gluteal region. Very, very straightforward answer. I don't think I need to look into the options as well. It is the pudendal nerve. Pudendal nerve is the one which gets affected, especially during SSF. We are all aware of it, right? So just remember that. And it is a factual recall. I have an EMQ based on these nerve injuries as well, because it's the most commonly asked. This is purely a factual recall. You need to know about the anatomy of this, because these are the very important procedures as an ST3 or ST4 you should be aware of. Again, the common question which they always ask, because I thought when we are talking about this, let's talk about the nerve vessel injury as well, the artery involved. In a forceps delivery, always remember the most likely artery which gets injured is superior gluteal artery. So just a gift slide for people, whoever is attending this session. Okay, let's move on. Fantastic. And definitely, they could give you details like which goes above the piriformis and how does that enter the piriformis foramen and all that. So that's why this slide. The next one, again, once again, looks like a factual one. Most appropriate antibiotic regimen according to NICE guidelines. Obviously, they would just give me the most appropriate antibiotic regimen. Let's see what is the scenario. 24-year-old man, 5 days, presenting at a clinic 5 days after undergoing surgical abortion. She reports new onset of lower abdominal pain with fever and a yellowish vaginal discharge. She was diagnosed with chlamydia prior to the procedure, but did not complete. Okay, there is a concern. She had chlamydia, but she did not complete the recommended antibiotic treatment. An examination, she is already having suprapubic tenderness. Fecalum examination reveals purulent cervical discharge. So we don't know whether it is exaggerated chlamydial infection or post-surgical abortion infection. Ideally, it has to be doxycycline and metronidazole, which is with azithromycin if it is there. Since that is not there, I would go for the best of the options, which is there. So I know doxycycline 100 milligram, 7 days, metronidazole 400. This looks like a correct dose. The next one, 500 milligram, no. Azithromycin plus metronidazole, probably yes, but it needs doxycycline as well. So 7 days azithromycin. Ideally, nothing has for PID like a 14 days, but in the options given, the best one could be option A. So that's why I'm going for it. Remember, if it is PID, then you go for 14 days treatment. And the best, post-surgical abortion, this would be the best treatment which you go ahead. Okay. The next one, what is the next immediate step? They are not asking me appropriate, they are asking me next immediate steps. Okay, so 32-year-old presents 2 days after undergoing oocyte retrieval. I know probably it is going towards OHSS. She complains of abdominal distension, discomfort, reduced urinary output oliguria. Examination, Abdomen is tense but not tender. She has gained 3 kg since the procedure. Initial fluid replacement has not improved her urinary output. This is a simple principle which I am aware. Whenever there is an OHSS, which is with oliguria, not responding to the fluid management, obviously the next best thing is to release the abdominal pressure so the blood supply to the kidneys could become better. So paracentesis, if it is there, I would be going for that as an option. 100% it is there. So that's why the option B. So if you understand the question, things becomes very easy. If you start analyzing, interpreting the scenario rather than interpreting the question, life is very easier. Okay, next one. Most important pre-op intervention. Okay, 55-year-old woman with type 2 diabetes is scheduled for elective abdominal hysterectomy. During the preoperative assessment, surgeon discusses measures to reduce the risk of surgical site infections. Here, I'm not sure what are the things they have given. So let's look into the options. Pre-op shower with soap, avoid routine hair removal, administer prophylactic antibiotics. That looks perfect. Administer antibiotics post-op. This I'm not for. Shave, no. Iodine-based, not required. Pre-op shower, plain soap, avoid blood glucose monitoring, apply non-alcohol based antiseptic. Okay. Delay antibiotics until after incision, shave the surgical site, no. Routine hair removal, no. So out of A and C, the best option would always be the A, because the difference between A and C is because there is no harm in monitoring the blood glucose levels. So I don't agree with the avoid blood glucose thing, because that is not something which you need to be doing, because that's something which is very crucial. So that's why it's obviously not my choice. The next one. Okay, this looks like again a factual one. Recommended hemoglobin level in the postpartum period, and how should this patient be managed? 30-year-old woman reviewed 48 hours postpartum after normal vaginal delivery, complains of fatigue and dizziness, hemoglobin is 9.8. So obviously, I know the values, it has to be more than 10.5. So I think that is the minimal level which you need to go about. So that's why that is the answer. These are the factual recalls which should never go wrong. Okay, next one. Okay, this looks like a scenario where I need to diagnose. What is the most likely diagnosis? 45-year-old woman is reviewed on post-op day 2. That's 48 hours. Following pH and GA. Okay. She complains of mild lower abdominal discomfort. So I'm reviewing her after 48 hours. GA, I'm not sure why she underwent under GA. Now she has abdominal discomfort, found to have tachycardia. Okay. Tachypnea. Okay. And there is a temperature rise of 38.3. Blood pressure is stable and abdomen is soft with no significant tenderness. So here, I might not be thinking of hemorrhage because of already the blood pressure remains same, but there is infection for sure. So there is tachycardia. So, and there is tachypnea. So there must be some infection somewhere, but let's see what is there. Chest infection, I'm not sure because they haven't given anything about cough or cold or whatever. Internal bleeding, as I said, blood pressure is stable. So I would rule out these two. Vault hematoma, I would still keep it in place. Pulmonary embolism, the only thing is tachypnea, but saturation seems to be very stable. UTI, there is still a possibility, but why tachycardia? Is it due to fever? So that also, this is also something I would keep it in mind. So I'm stuck with vault hematoma and urinary tract infection. But because there is nothing which mentions about dysuria or there is a tachycardia which is not proportionate to the temperature. And even if I consider that as a fever and UTI, why there should be a tachypnea? So looking into this, I would go for the commonest one which I can think of could be the vault hematoma. Of course, I do agree they could have given vault hematoma with infection would have been the best answer. UTI is still cannot be ruled out, but there is nothing specific for that. So that's the reason I'm going for vault hematoma. Definitely there will be some amount of fever, which is very well seen. And I think that is the reason probably we need to be going ahead and think of vault hematoma. Of course, the management could be, you could do a local drainage, you could do an ultrasound drainage and all that. Okay. But again, I agree in this question, there is always a possibility that you can get confused with the UTI, but unless they give you something like she has dysuria or she's diabetic or some immunocompromised, something like that, always go for the ones based on the observations. This is the dilemma with the postpartum. Okay. What is the next appropriate step based on Jehovah's Witness guidelines and ethical principles? Jehovah's Witness patient underwent surgery after refusing a blood transfusion and signing an advance directive. Post-operatively, the patient is tachycardic, hypotensive, dizzy, and disoriented. So I am dealing with a Jehovah's Witness who has signed her advance directive telling that she doesn't want to take anything. And now she's hemodynamically unstable. Let me look at the options. Follow the advance directive, yes. That is the one of the most important thing, which is an ethical principle. However, she's unstable. So let me see if I have other options. Administer crystalloids or synthetic colloids. Yeah, this could be given. Administer IV iron and erythropoietin. It might not work. Consult hospital ethics team. Yes, you are going to do this. You are going to do this. You are going to do this. Shift to surgery in his best interest only if intraoperative was previously considered. Yes. But now the thing is, see, I agree. E should be the best one. D is also correct option. C, I'm not for it because it's not going to help me. Out of these, they are asking the next step. So next step, I have only two. Either I follow advanced directive and do nothing, or administer crystalloids and synthetic colloids, at least to expand the volume till I do D and E. So for me, the best next answer should be B. Yes, because basically advanced directive is something which is always you have to be doing in her best interest, but it doesn't mean you cannot resuscitate the patient with the products which he is happy about. So that's the reason I think this could be the best one. So you are hoping that you are getting an idea which one to approach how. Okay, let's move on. Fine. So I think I have finished 10 SPAs. I was a little faster because you get only 1 minute for question. Still, I have taken 15 minutes for 10 SPAs. Let's go for your Q. My advice for you for single best answer is read the last line first. If you have 5-6 lines, read the last line. So when you are reading the scenario, you analyze what you're looking into, then go for the options and choose the best one. Okay, all the best. Let's go for our extended magic questions. As you're all aware, there are a lot of ways to do this. Okay, for me, the best way is I always read the lead-in statement first, because this is something which is going to tell me what I should be doing. I never look into the options first. I always read the lead-in statement, go through the scenario, and then go for the options. You could do whichever the way you're comfortable with, but practice that way and make sure that you get like 1 minute, 15 seconds, or 20 seconds for ETMQ. Let's start off. So the lead-in statement is, I know I'm dealing with a post-operative patient with complication. Appropriate diagnosis or investigation modality. One of the two I have to identify. Let's see here. So looking at it shows only investigations, probably the diagnosis what they're looking at. A 45-year-old woman underwent an extensive pelvic surgery 2 days ago for resection of complex ovarian mass. So I am thinking in terms of bowel and ureter already, because complex ovarian mass, broad ligament hematomas, ureteric injury, that's what is coming to my mind. Procedure was prolonged and involved significant dissection around the retroperitoneum. So I'm more towards ureter now. She now presents with worsening loin pain, and that radiates to her groin. So loin to groin, okay, something related to the kidney and ureter. She reports macroscopic hematuria and has a significant reduced urinary output, oliguria for last 24 hours. So again, I'm still stuck with kidney and ureter. An examination of vitals are stable, no abdominal tenderness. Bedside urine dipstick confirms the presence of blood, but no signs of infection. And there is a little rise in serum creatinine. So I am thinking in terms of kidney and ureter, probably in ureteric injury, because there is a more of a broad ligament involvement, and then probably because of ovarian dissection, because that was like ovarian mass. So I'm thinking in terms of ureteric injury. So obviously, when you go for this, there are a lot of things which you could, ureter and kidney. So if you could see, a lot of things are unrelated, right? Flexible cystoscopy, could be something which you can do. Measure urinary output, urinary analysis and culture doesn't work here. IVB could be done, but not now. It won't serve the purpose. CT urography, yes. CT scan, I don't think so. Rest of the things, percutaneous nephrostomy doesn't work here. So I think I would still go for the best option of CT urography. Basically, because this is one of the most important investigations which talks about ureteric injuries. CT cystogram you could still do, but I'm thinking in terms of ureter. So that's why I go for this. There could be a lot of similar investigation. I'm sure I'll have a slide for what are the different injuries and what are the different investigations which you need to go. Yes, this is your savior slide where I've given you bladder, ureteric, and bowel injury. Days like immediate post-op, always CT cystogram is the best here. CT urogram is the best here. CT abdomen with contrast could be the immediate one. Of course, the symptoms look almost the same for these two, and this will come with paralytic ileus. When you come for the early complications, you can repeat the cystogram or the cystography here. Ureteric injuries, after 2 weeks, you need to look into how the Dopplers of the kidneys are. When you come to week to month, you could always think of, because by then there could be a lot of damage. So you really, this scenario you generally don't get. You get usually this, not even this. Okay. So just know these investigations because that would help you to answer in the exam very well. Okay. So know which one is used for what. Okay. Hope that's good. Again, the next one is also talking something like this. 60-year-old woman, laparotomy for twisted ovarian cyst. So I can think of ureteric bladder, but let's see persistent nausea and vomiting. So bladder and ureter could be there, UTI could be there, but mostly bowel is what I'm thinking. Unable to tolerate oral intakes in surgery. Reports as she has not passed any flatus or had bowel movements. Okay, paralytic ileus could be or a bowel injury. Abdomen is distended, no guarding tenderness, bowel sounds are absent, her vital signs are within normal limits. Initial blood test shows no significant electrolyte abnormalities, thankfully, because that's one of the thing why the bowel doesn't move. Surgical site is healing well, no sites of infection. So obviously I'm thinking in terms of bowel. There must be some problem with the bowel. So first one which I would do is erect abdomen X-ray, right? Because you could do an ultrasound, but nothing gives information as much as erect abdomen X-ray. So this is for the bowel injury. It's as simple as this, guys. CT abdomen, CT contrast you could do, which could help you if at all, if you are suspecting guarding rigidity and there is a peritonitis, you could think of CT abdomen, but there is nothing much. The first bedside thing which you do is always remember, it would be 100% always erect abdomen X-ray which you do. Okay, fine. I think the next one is also talking about, okay, this is a different EMQ. Managing a woman who have undergone obstetric procedures and are experiencing post-op pain and vomiting. Choose the most appropriate one, what you want to do. Okay. 30-year-old woman underwent elective cesarean section under spinal anesthesia for her second pregnancy due to breech. 2 hours after returning to the post-op ward, she begins experiencing severe sharp wound pain, localized to surgical site, radiating slightly to lower back, reports persistent vomiting, and has not been able to keep any oral medications down. Vitals are stable. Thankfully, she is hemodynamically stable. Saturation is good. No known allergies. What she already has received paracetamol and ibuprofen, but she cannot take it. So obviously you are dealing with somebody who has a sharp pain. Okay, but there is nothing serious like intra-abdominal bleeding. You have to control the pain. So because paracetamol and brufen NSAIDs are not working, the next best would be opioids. But the problem with opioids is vomiting, right? However, this excessive vomiting could be because of the pain also. So the first best thing what you need to give is you are supposed to be giving an opioid. Which opioid you would be giving? There are lots of options here: diamorphine, morphine, fentanyl, ketorolac, pethidine. So what is the best option which you give us? IV morphine. Yes, when this is the topmost in WHO surgical analgesic ladder, It gives effective relief. Of course, this should be given by an anesthetist because there is always a problem. Whenever you give the opioids, you should monitor the respiratory depression part of it, right? And of course, I would have gone for IV morphine plus ondansetron. If these two were there, that was the best thing. Obviously, you have to supplement with the antiemetic, but the first most important thing is you have to control the pain. Okay. Of course, you could ask me why not IM morphine? You know that IV morphine works faster. IV paracetamol doesn't work. IV fentanyl, definitely you could give. But for the options, morphine is always better. Diamorphine is longer acting. It needs a longer management, longer monitoring. That's why you go for IV morphine. Of course, the options could be very different, guys. I'm just giving you the answers based on the options which I have got in front of you. Okay. Hope this is clear. And anybody has got any doubts, you can always feel free to drop the chat box. I'm more than happy to help. Looks like the same leading question. We have to choose the analgesia. Laparoscopic salpingectomy. So that was a cesarean section. This is a salpingectomy. She, after 6 hours, she complains of cramping, pain, and nausea, stating that she feels too nauseated to eat, but has been able to tolerate sips of water. She's able to take orally. No signs of peritonitis. There is abdomen is mildly distended but non-tender. Pain is 6/10, and observation seems to be fine. Okay, so she has no allergies or history of opioid use. Again, I would say here, if you go for, I can agree. If you go for IV paracetamol and if at all, if you're going for ondansetron combination, if at all, if it is there, let me check if you have. If there is IV paracetamol, there is IV ondansetron. I don't think there is a combination of both. Again, I would agree if it was 9/10 IV morphine, I would have agreed. Otherwise, probably I can still feel that probably you can try with IV paracetamol 1 gram. So probably, unless the question is changed, my answer could be IV paracetamol 1 gram because she's having a nausea as well and she doesn't tell much of pain. But if the pain score is higher, you can go for morphine. So this is a correction which I would want to do here. You can choose paracetamol 1 gram because you would still be correct because she has not received anything before. So I would still go for paracetamol, then I go for NSAIDs, then I go for opioid. So probably for me, the answer would be still C. Okay, so just unless it is given as 9/10. So let me correct it here in the slide and let me make this as 9/10. So then our answer will be correct of morphine. If at all, if it is of 6/10, I would say definitely you are correct in going for IV paracetamol. Okay. So because these are the questions which are prepared by me. So when I'm going through with you, probably I can identify what is correct and what could be the correct answer, right? Let's go to the next one. Again, the analgesia one. So here again, what they are trying to talk about is emergency hysterectomy, severe PPH. Oh my God. Okay. So 12 hours post-op, severe diffuse abdominal pain. See, she has already received IV paracetamol, IV ketorolac. She described pain as 8/10, worsening. She's unable to tolerate. Distended, soft, blood pressure is 125/80. Looks everything fine. And obviously they have given there is no allergies. Here, you might think of why not IV morphine. Okay. The reason, because this patient has already undergone like major PPH, such like hysterectomy she's undergone for major PPH. So you could put the IV morphine as well, but he is actually like almost like 12 hours post-op. So for her, the best thing would be to make sure that she controls herself with the PCA pump, because this is something which is very effective and for the ongoing management as well. So that is the reason I'm going for this, unless she has extremely severe pain which has to be continued with IV morphine. You can try with PCA morphine first. If that is not better, you can go for IV morphine. So you must be thinking where to use what. IV morphine when the pain score is higher and when you want a very, very, very quick relief, and when you have tried IV paracetamol and ketorolac. If you haven't tried anything, start with IV paracetamol and then go for ketorolac or NSAIDs and then go for the opioids. Okay. And if you have something like a later post-op period, you can try with PCA with opioids. If it is remafentanil, there could be a lot of other options. You can try with PCA. If not better, then you can think of going for IV morphine. So the approach is very simple. Okay, I think, I missed the leading statement. This must be for diagnosis. 35-year-old woman, because looking at this, elective CS, progressive leg swelling, mild shortness of breath, no chest pain, on examination, unconscious, oxygen saturation of 70%, tachycardia, S1Q3T3. You can close your eyes and say it is nothing but pulmonary embolism, because S1Q3T3 is something which is a very significant one, unconscious, such a lower thing with leg swelling given before. So DVT going for pulmonary embolism, right? So I think I had given, but I had added a leading statement. So obviously this was cause of collapse. Of course, this is quite a straightforward one. So I don't think you'll be going for peripartum cardiomyopathy, pneumothorax, MI, no, because there is already a history of DVT followed by which she is becoming apneic and, like tachycardic, and ECG is very, very specific. Okay, the next one. 48 hours after vaginal delivery complicated by MRP. She has been febrile, collapses. Okay, she had fever, she had an MRP and she collapsed now. Tachycardia, hypotension, distended abdomen with tenderness. She's cold and clammy to touch and the uterus feels tender and enlarged. Okay, so there are two possibilities. One is here, probably because she has got this temperature, tachycardia, hypotension, probably she's in sepsis. The second thing, if I don't look into this distended abdomen with tenderness, I could think of probably a bowel injury, which they have done during the MRP, which is a very, very vague explanation. But if at all, if I want to think of that, and the next best thing, and also the uterus is tense and enlarged. So obviously it has to be sepsis and she's in septic shock. Okay, so hope that is very clear with the approach. Okay, the next one is day 3 postpartum, had an operative delivery. She's breastfeeding her baby, she collapses, complaining of severe headache for 2 days. Examination, she's unresponsive, unequal pupils. Okay, unresponsive, unequal pupils. So there is something wrong in the brain, probably some hemorrhage. Her blood pressure is 190, 120, and she has no signs of fever or infection. So the worst headache everybody can think of as CVT, but when there is hypertension with like not unequal pupils, you will always think of subarachnoid hemorrhage, which is a thunderclap headache, which could cause severe morbidity and mortality for the mother. Okay, hope this is clear. I'm going quick with the approach because you need to understand how quickly you're going to solve these questions. Okay, this is simple. This is something to do with your nerve injuries in the factual recall. Most likely nerve injury. 32-year-old undergoes abdominal hysterectomy, complains of weak in her right leg and difficulty in climbing stairs. So there is reduced strength in hip flexion and knee extension, absent patellar reflexes, sensations decreased over anterior and medial thigh, which is nothing but the femoral nerve injury. Guys, you have a table in the chalk. Know these nerve injuries very, very well. Somebody who is unable to climb the stairs with all this typical one will always be a femoral nerve injury, probably because of the retractors which they used and also due to probably the positioning. Next one is also same. SSF, okay, for pelvic organ prolapse, severe pain in perineum, vulval area, worsens while sitting. So obviously this is nothing but the pudendal nerve injury, which had come as SPS, right? So remember, pudendal nerve pain with injury would always cause severe pain while sitting. They are better while walking or lying down, and especially sacrospinous fixation. Next one has to do with phenestrial incision. So there are two nerves, ilioinguinal, iliohypogastric. Burning pain radiating from incision to mons pubis, labia majora, upper inner thigh, reveals tenderness over incision site, but no motor weakness. So obviously this is nothing but ilioinguinal. If at all, if you're thinking of hypogastric, then they have to give to the lateral buttocks and to the lower abdomen, not to the mons pubis. Okay. The next one, weakness in her right thigh, difficulty crossing her legs. What is this? On examination, sensory loss in the medial thigh and weakness in hip adduction. So she's unable to close this one. So obviously this is obturator nerve injury. Generally, whenever you go for endometriosis, especially retroperitoneal, this is something which is very, very common, which remember the hip adduction. That is very characteristic of obturator nerve. Okay, the next one, I don't think I need to even read. Foot drop. Foot drop is nothing but common peroneal nerve. So know these nerve injuries, guys, because you should never go wrong with these injuries. Okay, I think I've covered more than 10, but let me go for the next one. Appropriate management. 28-year-old woman underwent laparoscopic cholecystectomy. 8 hours postoperatively, she complains of severe shoulder tip pain and mild nausea. Vitals are stable. Okay, so here, I know this is due to the gaseous distension, which can happen. So what do you do generally? You ask them to actually mobilize and probably ask them to go around. When that is, if it is not there, because, okay, it is there. I was thinking if it is not there, then because nothing else works there, you could give paracetamol and all, but if you don't treat the cause, it won't work. So ask them to ambulate, because basically shoulder tip pain is because of the accumulated gas, which they would have during the distension, during the trocar incision. Okay, so I think there are few last ones. Again, this is for the diagnosis. 32-year-old pregnant woman, diabetes, collapses in emergency department, found to be unresponsive, no pulse, cardiac arrest. Resuscitation efforts are initiated. She had been feeling unwell with shortness of breath. So obviously, I will think in terms of blood pressure was on a little higher, right? I would always think the first and foremost diagnosis as pulmonary embolism. Somebody who had breathing difficulties. 28-year-old woman found unconscious with pinpoint pupils. She has a PCA, obviously post-op pain management. So you know that opioid overdose always cause pinpoint pupils. Let's see what other findings they've got. Respiratory rate 8 breaths per minute. So I know there is an overdose of opioid. So the answer should be opioid overdose. And remember, naloxone could be the best one. And they have asked the dosages also before in other years. So know that as well. The last one, 35-year-old pregnant, history of type 1 diabetes, collapses at home. Husband reports that she seemed confused, irritable, examination diaphoretic, unresponsive glucose level. Obviously, it is nothing but the hypoglycemia. So guys, if you are in the right state of mind, if you are thinking very straight, and if you are only looking at the scenario-based explanations, then answers are automatically in front of you. I have done, I think, more than 15 EMQs. Of course, I've gone like a rapid fire rather than going very, very slow reading each of the option, because right now this is what you require to do it with a time frame. Hope this was helpful. I have added a lot of things. I know there could be questions. Please don't forget to like, subscribe, and share this, and drop your doubts in the chat box. I'm more than happy to help. Hope this was useful. Hope we are helping to achieve your dream. All the very best, and don't forget to watch the complete video. God bless, and may success be yours. Thank you so much.